All, this is Dr. Mobeen Sayed from drbeen.com. Today we are going to talk about a topic that has been asked a lot, and that is the statins and if they have a role in helping with the COVID-19 disease. So let us start our discussion. I am going to present this topic in a few sections. One is that what are the statins themselves? What is the cholesterol? What is the role of the cholesterol? What is the physiology of the cholesterol? Then how do statins help us reduce that? And then finally, how are statins maybe, how can they help with the COVID-19? And I'm going to use Mass General Hospitals from Massachusetts. I'm going to use their document for this plus a study. So the information here is coming from the hospital, and I'm using that instead of making a conjecture here. So let us start. Welcome everyone, and let us look at the statins. So first of all, here is a study. This study was, if you see here, this is 5/11, so May 11, 2020, and this is the effects of ARBs, ACE inhibitors, and statins on clinical outcomes of COVID-19 patient. The weakness of the study is that this is a retrospective study. It is not a prospective, double-blind, randomized type study. And what they did over here was they looked at ACE inhibitors, ARBs, and statins. The other thing that is interesting is, which I think is interesting plus a weakness of the study as well, and that is that the study is for those patients who were taking statins. So look, the folks who are taking statins, they may have a different lifestyle, they may have a different access to medication, they may have a different body habitus because of the cholesterol and the presence of the cholesterol causing issues that they had to take the statins. So maybe cardiovascular diseases or other things may be present in them, which kind of separates them from the rest of the population. At the same time, the folks who are who have some cardiovascular issues, they probably have a higher risk of the COVID-19 disease severity. So just keep those things in mind, and let's look at the study here. So if you see the study in here, what they said was a total of 154 COVID-19 positive subjects were identified. The outcome, what they wanted to observe in these patients were, number one, how long did they stay in the hospital? So these are those folks who were taking ACEI or ARB or statins. And secondly, they wanted to see if any deaths occurred within 14 days of the disease onset or symptoms. Their conclusion was, we found a statistically significant association between statin intake and the absence of symptoms during COVID-19 infection. So that is what they basically saw, that the symptoms were less in these patients. However, they also said the strength of this association was considerable and clinically important. And down here, they said there were also no statistically significant association between ACEI, ARB, and asymptomatic status. So this think that our data indicates that statin intake in old, frail people could be associated with a considerable beneficial effect on COVID-19 related clinical symptoms. The role of statin and any interaction with renin-angiotensin system drugs need to be further explored in large observational studies as well as randomized clinical trials. So again, it is not statin alone. These are statins with the other drugs as well. So with this, I am going to then go to this document. This document is a PDF by Mass General Hospital, Massachusetts. And here what they are saying is that people have talked about statins that may be beneficial. So they think that there may be 4 ways that they can benefit. And once we look at this document, then we'll go back and look at the physiology and possible mechanism of statins for COVID-19. So here, the point number 1 that Mass General Hospital is making is that the risk factors for severe COVID-19 presentation. So most of the time, the highest risk factors are diabetes and the cardiovascular. Although in the New York City, we saw that obesity was another important comorbidity that that dictated the severity of the disease. So here, the first point they're making is that because the patients who have cardiovascular issues, they may be taking statins because they had the cardiovascular issues, and such patients are already at a higher risk of intense disease. So maybe statins are going to help with the cardiovascular system and indirectly help them keep going into a disastrous state from the COVID-19. So that is one. Secondly, cardiovascular complications. So they're saying that it is possible, and we all know, at least the cool beans over here, we've been discussing this thing for a long time, that COVID-19 can cause cardiovascular issues. It can bind to heart muscle and cause issues there. It can bind to the endothelium or the blood vessels wall and the heart's walls and cause issues there with the ACE2 receptor and ACE1 receptor. And we've seen the inflammation and anti-inflammation and the imbalance that is caused, leading to endothelial damage or the blood vessel damage, causing thrombosis or coagulation. So they're saying that possibly if this may be a case with COVID-19, then giving statins may help reduce the vascular atherosclerosis and vascular damage. So that is their second conjecture they're theorizing. The third one is this is what I'll explain today, that statin and innate immunity. So we'll talk about that in a second, that the innate immunity, the macrophages and the dendritic cells, when they are going to capture a pathogen, they use multiple kinds of receptors to capture a pathogen. One of those type is called Toll-like receptors, or TLRs. TLR in turn use a pathway to start the inflammatory process. Remember, when innate arm will become active and they would catch a pathogen, then they would start the process of inflammation or process of immune response. So they're saying that statins can actually hamper with that immune response. Statins can block the immune response, and we'll look into that mechanism in detail today. And then is the statin and viral pneumonia. And they've said that some studies have shown that statins may be beneficial in viral pneumonia or even in COPD. I have gone and looked at those studies. I'm not very much convinced that statins had been that useful. Meaning, if I have to choose, let's say, dexamethasone over statin or ivermectin over statin, I would choose those drugs that have better efficacy instead of statins. But what this means is that if somebody is on statin, they should not stop using statin because statin are still protective. So this is the basic discussion. Then they have talked about the safety margin of the statins as well. And statins have been used for a long time. They are pretty safe. Yes, they have a couple of complications that in high dose or high intensity can be apparent. One of those is the muscle pains, because it can cause muscle damage. And the worst part in there can be rhabdomyolysis, where the muscle cells start breaking down. And the other one is liver effect, their toxicity to liver, because liver is very much active with the cholesterol mechanisms. And when statins go and affect the enzymes in the liver gets extra stress because of statins, and that can become damaged as well. So these are the two things that they have discussed here. With this, let's now look at statins themselves. So the dyslipidemias are really abnormalities of lipid profile in our body, which includes the cholesterols and the lipids and the triglycerides. So important thing is that the lipids are a major cause, or cholesterol is a major cause of atherosclerotic cardiovascular diseases. But please, the takeaway should not be that cholesterol is bad. Cholesterol in excess is bad. Cholesterol normally is needed to make so many things in our body and to keep our skin, for example, flexible and soft. All of those things are because of cholesterol. So we look at the outcomes of the cholesterol, that what does cholesterol help make? And you will see that it is an important substance that we need. But the cardiovascular diseases, for example, coronary heart disease can occur because of the high cholesterol levels, ischemic cerebrovascular disease or strokes, then peripheral vascular disease, that is the vascular disease in other parts of the body, And we also know that the cardiovascular diseases in developed countries are the #1 cause of death. And this may be because of the genetic life or the lifestyle. So genetics can cause the high cholesterol and or the lifestyle of the person as well in developed countries. So let's look at the physiology of the lipids. And this is a very brief discussion. If you would like, I can do a couple of talks, especially taking a detour from COVID-19, and we can talk about the cholesterol dynamics, the lipid dynamics in our body, and then the role of statins in more detail. If you are interested, we can do that. So over here, if you look at it, here is the dietary intake of fat and cholesterol. So the food that we eat, if it has fat and cholesterol, once that food enters our GIT in the small intestine, the food is converted, or the fats are picked up by the intestine, and then they are packaged into small microscopic packets. And these packets are called chylomicrons. So very quickly, the packet structure looks like this. So if you see here, this is the structure of that chylomicron. So chylomicron is a single layer of phospholipids. Outside are the phosphates, so that allow the chylomicron to freely float around in the water, because phosphates are water adherent, or they are water hydrophilic. They like water. On the other hand, the lipids do not like water, so they face the other side. And then inside the chylomicron, in the core of this, are the triglycerides and cholesterols filled. This is the chylomicron that is synthesized in our intestinal cells using the fats and cholesterol that we have eaten. You can think of this as a chocolate. Remember, there are chocolates which, if you eat that, in the core of the chocolate, there is some gooey, milky, sweet stuff, and then around that is a chocolate itself. Imagine that thing is a chylomicron. So in our intestine, chylomicrons are built from these fats and the cholesterol that we have eaten. Those chylomicrons are then sent into the body. And remember this, that normally whatever is absorbed from the intestine goes to liver first. And the reason for that is that, if I make here, so from the intestine, the portal blood system brings everything to the liver. And then liver does the first pass metabolism. That means it kind of detoxifies whatever is coming in, and then it lets that go into the blood. On the other hand, the lipids, the chylomicrons, do not go to the liver as first pass. They are picked up from the intestine. They are synthesized in the intestine and then pushed into lymphatic system. So they have a separate system which brings them directly to heart. So if there is heart over here, lymphatic system directly brings the chylomicrons to the heart. So they bypass the first pass metabolism, or the first chance for the liver to look into them and try to work with them. Then they become part of the blood circulation, and then they go to liver as well. So back here, from the liver, chylomicrons are built, and those chylomicrons have gone to the tissue. In the tissue, on the tissue surfaces, on the cell surfaces, there are enzymes either present in the vicinity of the cell surfaces or anchored on the cell surfaces. That is the LPL enzyme. So this LPL enzyme captures the chylomicron and then takes the free fatty acids out of it. So it takes the fats and cholesterols, it takes them out. And then it helps them store in the adipose tissue, which is the fat tissue. And then it actually, liver takes them up, kidney takes them up, fat tissue takes them up, other parts of the body takes them up as well, but liver is the primary one. So those, the adipose is another primary one. So the free fatty acids that are produced go to the tissue, normal tissue cells, plus they go to the adipose and are stored there. From there, the chylomicron, now we have been emptying the chylomicron, we've been pulling the things out of it, and then what is left is that empty vessel. So imagine if you make a small hole in that chocolate and drain the milk from it. Now that empty vessel that is left is called the chylomicron remnant. That chylomicron remnant is then sent back into the liver, and liver would then work with that remnant as well. Now, when the liver receives the chylomicrons as well, what liver does is it creates another particle which is called very low density lipoproteins. That particle is then converted in the circulation into intermediate density lipoprotein, which is then converted into low density lipoprotein. And this low density lipoprotein is what is dangerous. So imagine for today's discussion that we have two kind of things in our circulation. One are low life things. These are called low density lipoproteins. I always think in my mind that these are low life things because they hurt us, they damage us, so they are low lives. On the other hand, there are high life things as well, which are the HDL. And I would explain what is the function of the HDL in a second. But this LDL is good and bad. It is good because it brings the lipids and cholesterol to the tissue which need them. Our tissues need this to make, for example, steroid hormone, for example, to make the vitamin K, vitamin D, and so on. So there are many things that we make them. Bile salts are made from them as well. Our skin's, the flexibility comes from the cholesterol that is present in the cell membranes. So it is not that it is not needed, but the LDL's role is that it tries to just bring a lot of chylomicron and lipids and cholesterol to the cells, which may cause damage to the cell. And I'm going to look at that damage in a second as well. So continuing, the remnants of this LDL can then be picked back up by the liver. So liver has receptors to pick up whatever is left over. Now let's go here for a second and see how does LDL cause damage. Why is this important? Because when we talk about these statins, you would see that these LDL or cholesterol productions are reduced, and that is the function of them. So first we want to understand that what is going to happen when the LDL is present. So look, let's see here. Imagine that this is a blood vessel. So this was a blood vessel, and we have one surface of the blood vessel in front of us. On the blood vessel, what happens is that LDL, if you see here, LDL is picked up and is brought under the surface of the blood vessel. Normally, this process starts when a person is 9 years old. So it is not something that we can simply avoid. It starts when we are 9 years old, and it continues throughout our life. As we age further, more and more of the cholesterol is brought into the blood vessel walls. That causes the thickening of the blood vessel wall. That is called atherosclerosis. Plus it makes plaques as well, which we'll talk about in a second. So LDL is picked up. LDL is brought under the blood vessel wall. And in there, what happens is, remember the reactive oxygen species? LDL gets oxidized. This oxidized LDL is very dangerous, and it causes local inflammation. That is how the damage in the blood vessel wall starts occurring, which when repairs gets the plaques or the atherosclerosis there. Now, this oxygenated LDL is removed by macrophages. So in the blood vessel wall, there live macrophages, and we have become very familiar with the macrophages. We've become their friends in our discussions. Macrophages are part of the innate immune system. Where do macrophages come from? Our bone marrow makes monocytes. Monocytes come out of the bone marrow, go into the blood vessels. From the blood vessel, the monocyte migrate. They go to all tissues, including the walls of the blood vessel as well. So when a monocyte becomes resident, so if you see here, this is a monocyte, it is adhering to the blood vessel wall, then it would come out and become resident in the wall of the blood vessel. This is a good thing. We need them to be there, but this becomes bad in the presence of LDL. So what happens is that when LDL is present here, the macrophage is going to eat it up. Why is macrophage eating it up? Because macrophage thinks that this is a bad thing, and it is trying to clear that. So if you see here, this fat macrophage over here has taken up a lot of oxygenated LDL, and it has become very big, and we call it a foam cell. So under the microscope, when you look at it, it looks like a foamy cell. So because it has eaten up a lots of LDL or cholesterol in it. So foam cells are active macrophages. what they do is they become very upset that there is this pathogen. It's not a pathogen. There is this harmful substance present here, and the macrophages in turn start releasing cytokines and chemokines, and we know them. Remember, they release interleukin 1 and interleukin 6 and interleukin 8 and TNF and GM-CSF and so on. That starts the immune response in this blood vessel wall, which causes damage to the blood vessel wall, which creates the scarring in that area and aggregation of the platelets and hyperplasia of the smooth muscle cells. All of this is the plaque inside the blood vessel wall. So if I go here for a second, imagine that this is a blood vessel wall. This is healthy. And if this has developed a plaque, then what would happen is that this blood vessel wall now over here has developed this plaque-like substance, which grows inward towards the blood vessel wall. And this narrows the blood vessel. Now, most of the time, until the blood vessel is narrowed to 85% and above or 80% and above, clinically we do not feel anything. We are okay. However, there is a danger here. Number one, this plaque here, which is called atherosclerotic plaque, this might continue to grow and occlude the blood vessel. That is what happens with the cardiovascular diseases or heart attacks. The second problem is that our friends macrophages. Our friends macrophages do not like what is happening here. So they start eating up the plaque tissue. And when they burrow deep, when they dig deep in the plaque tissue and try to eat it up, they make the plaque very weak and vulnerable. And what happens is that this plaque can actually open up. So if I break parts of the plaque, what can happen is that, number one, pieces of the plaque or this damaged, this scarred tissue or plaque would break away, and they would now go in the blood and they would get stuck in some other blood vessel, causing heart attacks or strokes. The other thing is that this plaque itself can act like a leaf, because now it is weak and it has been burrowed in and it has been damaged. So that plaque leaflet can actually open up and block the blood vessel itself. So this is what is happening because of the LDL. And because of the immune system response, which is primarily driven by macrophages. Now, what is the role of HDL in this? HDL, or high density lipoprotein, they are also small particles that have lipids and proteins in them, but their function is interesting. The kind of proteins and lipids that are present in the HDL particle, they are, if you see here, they are antioxidants. These are anti-inflammatory. So these are enzymes and proteins present in the HDL. So you can think of HDL as a big vacuum. It's a doctor, someone like me. It's a doctor who's carrying a kit of various enzymes that would help heal the damaged blood vessels. Plus, it has a big vacuum with it as well. So imagine a doctor with a kit, medical kit, and a vacuum. What it does is HDL can actually pull the cholesterol out of the foam cells. It can also pull the cholesterol out of the membrane of the cells. It can vacuum them out. Plus, it has enzymes that would do a bunch of things, which I'm going to show here. So number one, HDL has enzymes that can stop a monocyte from adhering to a blood vessel and going into the blood vessel or into the blood vessel wall. So that would help. Then HDL, if you see here, HDL can block the oxidation of LDL, and that would block the further damage in the body that would occur, or the blood vessel wall that would occur because of the oxidized LDL. HDL can also block the proliferation of the smooth muscle cells in the vessel wall. HDL can also block the aggregation of platelets, so the plaque formation stalls or reduces. HDL can also ask the blood vessel wall cell, endothelial cells, to release nitric oxide, PGI2, and other CNPs, other substances that would help, number one, dilate the blood vessel, and number two, fight with the inflammation that is going on. So HDL is helping and LDL is causing issues. So if you see here, this is that mechanism I'm showing here. So imagine this is a blood vessel wall or a normal tissue cell. So some cell in the tissue. LDL will come to it and deposit cholesterol and lipids for that cell. And as I said before, it is actually interesting for the cell to have cholesterol. They need cholesterol to do their function. Plus, they want to keep their cell membranes fluid, and cholesterol helps with that fluidity. So they are necessary, but a lot of cholesterol when present in the cell would cause damage, as we just saw. So HDL comes along and it tries to pull the cholesterol from inside the cell and from the surface of the cell. And it takes that cholesterol that it pulled from the cells to liver, where liver can further metabolize that, or adrenal glands, which can use it to make steroid hormones, or ovaries and testes, which can also use for the androgenic hormones metabolisms. So eventually HDL is a great doctor who's helping the community of the cells to not become sick. On the other hand, LDL in its intent is trying to help, but in that process it is causing inflammation. So this is a brief physiology. Correct. So Jim, there is a comment there that but only oxidized LDL is bad. That is absolutely correct. The problem is that when LDL comes into the blood vessel walls or other tissues, it can become oxidized very easily, but LDL is necessary as well. Now, continuing on with our discussion, I want to now talk about the statins. So the formation of cholesterol is called a mevalonate pathway. So what happens is in our metabolism, we have acetyl-CoA produced as part of the metabolic pathways. Acetyl-CoA is then converted to HMG-CoA, another substance. HMG-CoA is then converted into mevalonate by HMG-CoA reductase enzyme, this enzyme. This is the important one because this enzyme is going to be blocked by statins. So HMG-CoA is converted to mevalonate. Mevalonate then gives rise to there are multiple downstream path steps. I have omitted them here because this would have become a very long flowchart. But the result of mevalonate pathway is that we make CoQ10 from the substrates or in the next steps. We make vitamin K. We make cholesterol. From the cholesterol, we make bile salts, which are necessary to absorb lipids or to emulsify lipids. Then we make steroids, which are necessary for our body. We make vitamin D, which is necessary for our body. So this is the normal pathway. When somebody has more cholesterol produced and there are bad effects of cholesterol present in the body, then we give statins. What statins do is they go and they block the HMG-CoA reductase enzyme. This enzyme is a must enzyme for the remaining pathway to become successful. So when we block the HMG-CoA reductase enzyme, then the production of cholesterol and all the other things here will reduce. And the result of that is that the person has less LDL and less cholesterol available, which would then cause less atherosclerosis. Now, statins are must in patients who have, number one, who are at high risk or who have had cardiovascular disease, for example, a heart attack or a stroke. Now, with this, let's now look at the final point for today. This is what the Mass General Hospital's paper was talking about. And they were actually talking about it looking at this study. So here is a study here. So if you see here, this study is actually from 2015 August. And this study was done on MERS-CoV, Middle East Respiratory Syndrome virus. That was also coronavirus. And what they had done was, in this study, they found out that if we are giving statins, then statins can cause a blockage of a pathway which is called MYD88 pathway. And that blockage of the pathway reduces inflammatory response in the body. And that's what I'm going to talk about. Mass General has used this study to talk about the little paragraph they have. So let me show you here. So imagine this is a macrophage, little bit more in detail. So macrophage has receptors on its surface, which are called toll-like receptors. They have many kind of receptors that can capture the pathogens. Macrophage and dendritic cell, their function is to arrest the pathogens, eat them up, break them down, present them on their surface, then talk with the naive T cell, and then help the naive T cell become T helper 1 or T helper 2, and then the adaptive immune response comes in. This is the same macrophage. We are just looking at it a little bit more zoomed in on its initial function of eating up a pathogen. So if you see here, macrophages have Toll-like receptors on them. Toll-like receptors can detect various patterns on pathogens, on viruses and bacteria. And when they detect those patterns, they then capture them and they eat those things up. They phagocytose them. That means they would then engulf them. Once they engulf them, the pathogen comes in, and we know the remaining pathway for the pathogen, that it would be presented on the surface of MHC2, then a naive T cell would come along and that would become activated. I'm not going into that pathway. I want to show here that when Toll-like receptor becomes active, then inside it causes another substance called MyD88 to become active. That pathway then activates nuclear factor kappa B. And we have talked about this since vitamin D days. This nuclear factor kappa B goes into the nucleus and allows the nucleus to do the gene transcriptions, or it opens up the genes that are necessary to make interleukins and chemokines. Which interleukin and chemokines, if I can ask you? Interleukin 1, interleukin 6, interleukin 8, tumor necrosis factor, then GM-CSF, and so many other interleukins and cytokines are produced. So this is that one of that pathway that helps make that. So of course, when the interleukins and cytokines are produced, we have been talking about it a lot in our discussions, that would give rise to the inflammation. That would give rise to the immune response. And we know that in COVID-19 patients, that immune response can run away and become bad in some patients and cause even death. So here, look at how statins help. When statins are present, they block this pathway. So when the Toll-like receptor becomes activated and it wants the MyD88 pathway to become activated, statins block this pathway. When they block this pathway, nuclear factor kappa B is not produced in sufficient amounts. That means inflammatory response is not in the sufficient amounts. That causes reduction in the inflammation, especially in the areas of the lung as well. So this is how statins can help with the COVID-19. So that is the discussion for today. Whatever studies I studied, so I looked through a bunch of studies today. I am not convinced that statin themselves as a therapy is very, very useful. However, giving them has protective effect. So somebody who's taking statins should continue to take them. Somebody who's in a serious situation in the hospital, I think Math Plus protocol advocates with statins as well. So this is the mechanism that we just looked at. So statins can be useful. They are not harmful, especially when given in the shorter period of time. In the longer period of time, muscle pains and liver damage can occur, but they are pretty safe in therapeutic doses. One more thing, that statins, when given or recommended in the COVID-19 in serious cases, they are given in high intensity or intermediate intensity, not in the low therapeutic doses. So that is the discussion for today. I think that whoever is taking statins should continue to take statins, and hopefully from the studies, it seems that they are a little better protected. Somebody who is not taking statins should not start statin for COVID-19, but if COVID-19 occurs, it is possible that statins can help. So there's a comment, Mary says that, I don't know how. So Mary, one part of this is that I study through the day, and I make sure that when I'm presenting something to you, it becomes an asset. One difference that I have, so some people have been talking with me saying that MedCram does similar talks, or John Campbell has talks as well. What I have been trying to do is I've been trying to go into detail into the weeds of our system, because that allows you, that enables you to think deeply and then you can look at various drugs and can understand what is the mechanism. So you don't have to take it on the face value that somebody said that, hey, this is how it would work, and this may be how it helps. You can actually look deeper all the way down to the cellular mechanisms to see how it helps. So that is my that is my motivation for going into the depths. So Patrick says that the devil is in the detail. Absolutely. So please remember, tomorrow we will have Dr. Paul Marik with us. He's the author of Math Plus Protocol. Same time, day after, we will have Dr. Zelenko with us. But the time is going to be 2 p.m. Eastern time or 11 a.m. Pacific time. So my time, we will be 7 hours earlier. We'll be going live 7 hours earlier. Then next week, hopefully we'll have Dr. Bruce Patterson with us. We will have a couple of more doctors as well. So I think you would really enjoy those discussions. So stay tuned for tomorrow. I'm pretty excited for having Dr. Paul Marik. It is funny, yesterday I was talking over the email with him, and Dr. Paul Marik actually sent me an email in which he shared some document with me. And then in his signature, he had written your subject, and his name, he had put soybean. So because I call all of us cool beans, he called me the king bean, and then he called himself the soybean. That was pretty funny. So I liked his sense of humor there. So guys, thank you very much. My request to you, please like, subscribe, and share. That would be your favor to me. And see you tomorrow with Dr. Paul Marik. Bye-bye.